hemodynamics, we have to know the basics of hemodynamics. And so we're going to start with the waveform, the anatomy of our arterial waveform. We all know normal sinus rhythm, so we won't go into that, but we will do the waveform. And so by the time you finish with this class, you're supposed to be able to describe the components of an arterial waveform and analyze an arterial waveform, right? And so, anybody know why we have an arterial waveform? What does it reflect? Okay, so, yes.
The opening and closing of the valves.
Okay, well, not quite, but yes, part of it.
Are you talking about the repolarization and depolarization of the...
Yes, part of it. But your arterial waveform actually reflects the pressure generated in the arteries following the ventricular contraction. And it can be described, there's 4 components to it. Anybody knows any of them?
Dichrotic notch.
Yes, we have a dichrotic notch, but where is our dichrotic notch?
On the downslope of the
Downslope? Okay, what do I do here?
go up and come down.
Okay, all right. Where's the rest of them? Upslope? Okay. Am I drawing? Okay. So, arterial waveform, okay. So the 4 components, we're gonna name them A, B, C, D. Okay? So what do we have here? From A to B?
And front.
So that's your upstroke. What's happening at your upstroke?
Ventricles contracting.
Right. So your ventricle is contracting, and we have what we call isometric volume happening. So what's that? It is the same amount of pressure. You have the same volume but different pressure. So say for example, you have this bottle of water, okay? I am squeezing it. The volume came up, but I haven't changed the volume inside the bottle, but the way it is, it's just showing a different because I put pressure on it. That's your volumetric pressure. Okay, so once your left ventricle have enough blood and it gets the impulse to contract, when contraction starts, for it to open the atria, the aortic valve, it builds up a whole lot of pressure because it has to overcome the pressure behind the valve. So you build up your pressure, and this is called the anacrotic notch. Okay, I'm not good at spelling, sorry. So your anacrotic notch, you come up. What happens here?
Valve.
Right. So what happens here?
Pressure's equalized
Your pressure equalizes. So the pressure in your left ventricle
in the aorta.
and the aorta equalize, it will open the doors. So what happens is that you get a peak systolic pressure. So once you get to peak systolic pressure, I always say it vomits everything into the aorta, right? And so you start having a downward trend, okay? Your downward trend is?
Closing of the valve.
So that's your dichrotic.
No.
So you have it finish here and it here. Right? What happens at the dichrotic notch? Okay. And what caused the valve to close?
Pressure.
So the pressure changed. We don't have that elevated pressure anymore. The pressure in the aorta is heavier, is higher, and so your valve just closes. So what caused that dichrotic notch? When the valve closes, the valve to your lungs also closes, right? So your pulmonic valve closed also, and so you get that, it's like a hiccup. It just give it a little, like a bump in the road, okay? So you get that, and so you get that little notch. At that time, what happens? Once your valve close, your aortic valve close, what happens? What does that mean? Your ventricle is empty, what is happening now? Okay. When your ventricle is filling, okay? When your ventricle start filling, your diastole has started. Okay? So you have the dichrotic notch, and so you end up having diastole. In diastole, what happens to the coronary arteries?
They fill.
That's when you fill. So if you have a patient who have a very elevated diastolic pressure, and they're complaining of chest pains, right? What do? You call the doctor and you let them know. Because it's probably, he's getting pain not because he has coronary artery disease, but because his pressure is so high, the arteries are not relaxing enough for it to get filled. And so they need to give him something that will relax it, and so that they can do that. So you have your dichrotic, so you have, okay? I'm not a very good speller. Okay. Systolic pressure, right? Okay. We have something that we ask every time. It's called end diastolic pressure. Anybody understand that?
Filling pressure.
Okay. What does that mean to you?
At the end of diastole, which is after, the ventricles have contracted, the ventricles have contracted, that's the amount, of volume that I have remaining in my ventricles after they contract. Or after.
Actually, not quite. It's kind of backwards, but that's a good attempt. Anybody else want to try it?
Filling pressure.
When they
It's
fill.
your fill-in pressures. So it's the ventricle has already filled before the isovolumetric pressure starts, before the contraction has started. So therefore, it's like I've drank all the water I can, I'm no longer thirsty, and just before I want to know, before I move, right?
Yeah.
So this is what I need. So, yes. So just before, so this is going to repeat itself. It will start again and come back at it. So they will take that pressure registration at the end of diastole when I'm filled already before systole. And so we're gonna look at the end diastolic pressure. Anybody knows what the normal end diastolic pressure should be?
Less than 15.
So in actuality, they like it to be, so your end diastolic pressure should mirror your wedge pressure. Okay? Your end diastolic pressure should mirror your wedge pressure. And that goes from 6 to 12. Okay? He said 15. That is not wrong because sometimes numbers means nothing without a patient in front of you. So sometimes a 15 of an end diastolic pressure is a great pressure because that's the best you can do for that patient. Okay? Now, 2 low pressures, what would you do? If the end diastolic pressure says like reading like 2 or 3, what do you do? Or what do you expect your doctor to tell you to do?
Open the fluids.
You hydrate the patient. If the patient is, say we say 20, 24, what do you expect? Lasix. We expect to diurese the patient. So we know what we need to do, and that's how you get your hemodynamics. So you look at what the patient present, how they present it, and then you treat. Okay? Any other questions?